Hello everyone. Thank you all for joining our webinar today. I am happy to be able to share this information with you with our partnership with Ms. Leslie Steinman. So we're going to get started in a short minute. I'm just going to give people a couple of minutes to join, and then we'll go over some rules for today's Zoom meeting, and then we'll get started with our presentation. And thank you all for joining. I'm just making sure that I have everything pulled up for us all today. I will be making sure that I'm moderating the webinar chat. If you guys have any questions or issues or anything like that, please feel free to put that information in there. And we can go ahead and get started. So I'm going to go ahead and share my presentation. Thank you all for joining. Hold on one second. Okay. Leslie, everything looks good to go? All right. Well, thank you all for joining us today, and welcome to our webinar, How to Do In-Person Health Promotion Programs Work When Delivered Remotely, Lessons Learned from a National Process and Outcome Evaluation to Improve Older Adult Health Equity. The Society for Public Health Education, we want to thank you all for joining us today for our presentation. We appreciate you all being able to join with us today. The Society for Public Health Education is an exclusive organization of health professionals, and we welcome your whole self. The Society's mission is supporting leaders in health education and promotion to advance health equity in communities across the globe. Members include health education professionals, students throughout the United States and internationally. The organization promotes healthy behaviors, healthy communities, and healthy environments through its membership, its network of local chapters, and its numerous partnerships with other organizations. I am Jade Hackley, the Society for Public Health Education's Office and Project Associate, and we are pleased that you all are interested in the webinar and are truly thankful that you've taken your time out of today to participate with us. We do have a couple of housekeeping rules. All participants are muted when entering the meeting, so please unmute yourself to comment on anything that you have, any questions or anything like that during the meeting. I'm sorry, please do not unmute yourself during the meeting to comment. Put everything in the chat, and I will be making sure that I'll be watching that throughout the chat so that we can address all your questions. Feel free to share any information that you have that you think will be beneficial to our other participants in the chat as well. And you can also make sure to raise your hand once we get into our Q&A so that we can call on you to go ahead and answer your questions. For our phone-only participants, you need to press 6 for muting, unmute, and to raise your hand. Once you have your hand raised, if there's any time where you're on the phone, I will be able to accommodate that as well. And for video participants, please make sure that you're using the chat function. That way we have everything recorded, and we'll be able to share this information as well, because all of this will be all of the information that's put in the chat, as well as the webinar, is being recorded and will be posted on our eLearn platform. So before I hand it over to the speakers, we have gone over our housekeeping items and everything like that. So just please feel free to make sure that you're interacting with us with the chat. Now I am excited to announce our speaker for today. Dr. Leslie Steinman, PhD, MSW, MPH, she, her, is a research scientist at the Health Promotion Research Center, a CDC-funded prevention research center at the University of Washington School of Public Health. For the past 20 years, she has partnered with evidence-based health promotion programs, participants, providers, administrators, and policymakers to understand, adapt, and improve program delivery to address disparities in access to care and health outcomes among underserved older adults. Her other passions include spending time outdoors with her family in the beautiful Pacific Northwest. And now I will go ahead and turn it over for Leslie to begin our presentation.
Thanks, Jade. And Jade, just heads up, the presentation is in presenter view, so just, oh, you got it. You know what you got this. Thanks, Christina, for calling it out. You don't need to see all my notes. So welcome, everybody. It's great to meet you by Zoom and have some new and familiar faces here. My name's Leslie Steinman, and I'll be chatting today about our project, which truly would not have happened without all these partners listed here today and all the folks out in the field doing this good work. So I do want to give a shout out particularly to Sophie and CDC who are on today's call, as well as our other funders from ACL, NCOA, and Retirement Research Foundation and RTI. Next slide, please. So we'd love to get to know who's in the Zoom room. If you could let yourself know in the chat, maybe just put your name and your organization. We're going to talk about evidence-based programs in a little bit and which programs you're doing. So take a moment to let us know where you're here from. And then Jade's also going to put up a poll just so we can get a little bit of a sense of what type of organization you're joining from, as well as your role doing programs. And the reason it's helpful to do that is so I can kind of tailor a little bit the presentation to your needs and your strengths. So Jade, if you can go ahead and launch the poll, and folks can type in the chat and the poll, and we'll get to know each other a little bit before we dive into the presentation.
Yeah, no problem, Leslie. Just give me 1 second.
Sure, great. And I can see we've got folks from West Virginia and Oklahoma on the line, the National Arthritis Foundation, Vermont. I'm here in Washington State in Seattle, Utah. Great, nice representation. I hope everyone's staying relatively cool with the heat we've been having last few weeks here.
Okay, sorry about that, Leslie. It looks like I'm having some issues with that first poll, but I do see we're having some good participation in the chat. So thank you all for participating. It's great to see how far our reach is going with this information and to know, what other types of organizations are interested in this material.
Great, thanks so much. Yeah, I see Minnesota's here as well. Good to see everyone. All right, let's go ahead and keep going and dive in the presentation. And if you're just joining the conversation, let us know your name and where you're here from. We'd love to see who's in the Zoom room. So I just want to be clear, and before we start and talk about the lens I'm bringing to this work, thinking about positionality, we bring our biases, our lived experience, our training to how we have these conversations. And today I'm going to be talking about doing evidence-based programs for older adults, many of whom are living with multiple chronic conditions and experiencing financial hardship and facing inequities due to being a member of a community of color, a minority community in terms of sexual orientation. And so I'm a privileged, white, straight woman who doesn't have multiple chronic conditions. So I partner with organizations and participants of these programs to make sure that the work we do really represents their voices. I've got a lot of different hats with evidence-based programs. I administer a depression program called Pearls. I've been a trainer and a leader. I also provide coaching. I'm a researcher and evaluator, and most importantly, a partner to organizations like you. So I'm looking forward to getting to know you today and continuing the conversation going forward. Next slide, please. So today I'm going to talk a little bit about the background of our evaluation work, what we did and how we did it, what we learned, and then we're going to open it up for discussion. Please feel free to put questions in the chat as we go. We're going to have time at the end, but particularly if there's clarifying questions, I'm happy to weave them into the conversation. Next slide, please. So first I want to talk a little bit about what evidence-based programs are so we can make sure we're all on the same page, and talk a little bit about the context with the pandemic and COVID, and the need for the programs to be done remotely. This is really what set the stage for this work. Next slide, please. So what do people want from evidence-based programs? I know we typically talk about these as health promotion programs, but really we think more broadly, health is about getting your lives back. Maybe you're afraid of falling, or you're struggling with low mood and depression and isolation. Maybe you've recently been diagnosed with a chronic condition, and it's really kind of created some upheaval in your life and you need to create a new normal. So these programs are really meant to be empowering and teach skills based on sound behavior change theory to help people live the lives they want with their grandchildren, with their families, etc. Next slide, please. So what is an evidence-based program? These are programs that have been tested in research studies using experimental or quasi-experimental designs. They've been translated, so not just done as part of research, but are being done in community and clinical sites. The research has been published in a peer-reviewed journal, which suggests there's been an independent review of the quality of the evidence. And then there's tools, there's products like trainings, websites, marketing materials that have been developed and are available for use in the public. So I put this definition here because different agencies define evidence-based programs slightly differently, but these are kind of the themes and similarities across the different federal and national and state agencies that define evidence-based programs. Next slide, please. So why do evidence-based programs? There's a lot of good reasons for this. One, they work, they are effective. As I mentioned, the peer review means there's some independent review of quality outside the research team. They have outcomes. You're going to get something from the program. You measure them over time. You know that somebody's going to improve their self-efficacy for managing their arthritis, or improve the number of minutes they're physically active. These programs can be replicable because they have manuals, trainings, tools to support you. Those protocols really help assure quality, but also make your job easier to deliver these programs. We also see these as a responsible stewardship for funding. These programs were developed with often taxpayer public dollars, and then using these programs allows us to continue to know what we're going to get for our dollar. These outcomes are going to be proven and effective. They can be efficient. These programs are meant to be relatively low cost compared to some clinic-based programs. And they're also meant to be sustainable. This is something we're working on, right? Trying to get payer support, insurance support, so that you all can support these over time. And grants from places like CDC help get these programs started and build networks for sustainability. Next slide, please. So I'm curious, because there's some new folks in the room I haven't had a chance to meet before. Take a moment and type in the chat, what evidence-based programs are you delivering? And I know some of you are newly funded through this EDC arthritis program. So it could be you're just getting started, or you've been doing programs for a while. So these can be falls prevention programs, self-management programs, behavioral health programs. So take a minute and let us know which programs are in the room today. Thanks, Kelly. So we've got Tai Chi Quan Movement for Better Balance, the Arthritis Foundation Exercise Program, SAIL, which is also a physical activity program, and the Diabetes Prevention Program. Also seeing the Self-Management Resource Center program, Stepping On, Walk with Ease, Enhanced Fitness, Pearls, Managing Living Well for Arthritis, chronic pain, chronic disease. Nice. So really nice mix of wisdom in the room. And I'm really looking forward to hearing about implications for the findings I'll be sharing today, given several of the programs mentioned in the chat are programs that we evaluated as part of this remote evaluation. Thanks everyone for taking the time to share. Next slide, please. So let's remind ourselves, it is in the distant past now, but it also feels like yesterday. 3 years ago, in the spring, our lives were totally upended with the COVID pandemic. And that really set the stage for the evaluation work that I'm going to be talking about today. Next slide, please. So during the COVID pandemic, we know older adults were really disproportionately impacted, right? Older adults had the highest rates of death and hospitalization. And this was really just a stressful time for people as at the early stages of the pandemic, particularly, we didn't know kind of what was safe. There was a lot of anxiety and there were a lot of restrictions in terms of leaving the house and connecting with people physically and socially. So traditionally, evidence-based programs have been done by organizations that are meant to really reach and empower older adults who are historically underserved. So this seemed potentially like an opportunity if we shifted in-person evidence-based programs to remote or teledelivery to basically make sure that older adults were not losing out on these really important health promotion programs to keep them healthy and safe. We do know, however, that doing things remotely or telehealth can present both opportunities to improve access to these programs, as well as challenges given things like the digital divide and people not having great access or comfort with using technology. The other context for this work is that as COVID was happening and people were sheltering at home and many services were disrupted, we felt potentially there was an opportunity that these programs could not just promote physical health and mental health and well-being, but could also address these rising social isolation and loneliness. So this kind of was the context with which we decided to come together with partners and do this evaluation. Next slide, please. So when I say remote, I mean a bunch of different things. I mean programs that are done asynchronously online. So that means you're not doing a live program, you're plugging in and watching some trainings, watching some videos, maybe connecting with people through a chat. There's video conferencing platforms like we're using today, Zoom. There's mailing materials such as toolkits and manuals, and then getting phone support or video conferencing support with a group or one-on-one from a program leader. There's also mailed programs that are more self-paced. You get the materials and it's up to you how you use them. And then a lot of programs experimented with a combination of such. So when COVID first happened, many in-person evidence-based programs were not being done remotely. And then over the course of the pandemic, programs began shifting to different modes based on the program content and the format and really what their communities asked for. Next slide, please. So why do an evaluation? I love this slide because it reminds us like that evaluation can really help us do our work better and support your organizations, your leaders, and ultimately program participants. And I think the reason we really set out to do this evaluation is because it was a little bit of Wild West when COVID first happened and programs started shifting to remote. And we really wanted to like have real-time learnings from both the successes and the challenges so we could guide future policy planning and action. And that's why we're excited to have this opportunity to talk to you today, because we're now at that point where we can put these findings into action. Next slide, please. So what set the stage for the evaluation was we did back in 2020, the Evidence-Based Leadership Collaborative did a just quick survey of what was happening with remote evidence-based programs to try to get a sense of what was being done, how many people were doing this work, who was being served, what was working well and not so well, and how to do this work better. And we realized that we really needed to do a more in-depth evaluation to understand what was happening and whether these programs were working. Next slide, please. So we really crowdsourced funding for this work, and I want to just give kudos to the folks on the line from CDC and SOPHE that came together to do this, because this was a tough time for everybody. We were working from home with our kids around, our aging parents, and we basically combined different sources of funding to provide funding for this national evaluation. And I really want to highlight the strength of the collaboration, our trust, our kind of just being courageous. Let's just do this and figure out how to do this well, and being comfortable with good enough. I'm going to talk a little bit about how the method shifted throughout the evaluation because it was a tough time to collect data, let alone deliver programs. So this is kind of how the crowdsource went together. Next slide, please. And these are the funders I had acknowledged earlier. I do want to say we had all of our funders and partners involved in advising the project in terms of what questions to ask, what methods to use, and then implications of findings. And it was really a nice example of public-private partnerships from aging social service and public health sectors coming together, which is really what we need to do to keep doing this work going forward. Next slide, please. So I'm going to talk a little bit about the evaluation design and methods and how we adapted along the way. Next slide. So overall, our purpose of the evaluation was to evaluate remote evidence-based health promotion programs. We were interested in both effectiveness or outcomes. Do these programs still work? Are we still getting the same health benefits? And then how are they working? So more of an implementation or process evaluation. And our goal and really our potential impact of this work is to make sure we're improving equitable access to quality care and health outcomes among older adults, and really making sure we're prioritizing those populations who've traditionally been underserved by clinical care, because that's really where evidence-based programs came from, trying to fill that gap and meet people where they spend 99% of their time, in their homes, in their communities, where they age, live, work, pray, and play. Next slide, please. We used an implementation science lens to guide this work. So implementation science is a field of study that really tries to bridge the gap between what we know and what we do in practice. And we used a framework called REAIM that was developed by Russ Glasgow and colleagues about 20 years ago, and was recently adapted to really try to make sure that we're not just improving or closing that no-do gap, but we're doing it in a way that doesn't further exacerbate inequities in both access to care and health outcomes. So we tried to do a project that was very real world and pragmatic, that the findings would be helpful for you all. We engaged stakeholders throughout the process. And again, as I mentioned earlier, really to guide practice and policy. Next slide, please. We used a mixed methods evaluation. So we use quantitative data, such as asking participants questions about their health at the start of the program and 6 months later, to really get a sense across programs and across the country of what is happening. How are people's health changing over time after they participate in these remote programs? Just as importantly, though, we collected qualitative data to really understand kind of why and how these outcomes are happening. And this is really important because this helps us understand when things don't change the way we think they're going to, what's happening, as well as provide useful information to support your program delivery going forward. We then integrated the findings to compare and contrast and really expand our learnings. And as I'll be sharing today, we really tried to make sure we had both stories and data to share to guide policy and practice, because we know that both those things are important for practice and policy change. Next slide, please. So our timeline was originally that we were going to plan the project in late 2020, we'd collect data in 2021, and then we'd do the analysis and interpretation and dissemination in 2022. What actually happened is the planning took a heck longer than we planned, right? There was COVID, we had various processes with internal OMB, IRB kind of things, and everything just took longer. You all remember this time, right? This was COVID. So we didn't actually collect data until later in 2021 and into 2022. And then we really just in the past year, we just submitted actually our paper for the outcome evaluation I'll be talking today, have been doing the analysis and interpretation. So it took longer than expected, which we weren't thrilled about. But at the end of the day, we're kind of glad the timeline got shifted a bit because it gave people more opportunity to participate and not be only delivering these programs under the stress of the pandemic. Next slide, please. So in terms of how we recruited evaluation participants, we tried to use different methods to make sure that we engage diverse organizations. So different channels were used, such as the existing program network, so training networks, TA networks, listservs. We use partners such as the folks from CDC and Sophie on today's call, who have grants and have other professional networks out there. And then we kind of did recruitment in a lot of different ways because we knew how hard it was to reach people during the pandemic, right? People weren't congregating and coming into the office or coming into coalition meetings. So we did one-on-one phone outreach, we did webinars and virtual meetings, we sent emails, and then we kind of embedded this ask into trainings once people were getting trained to do programs. And then once we engaged, we tried to really communicate regularly as best we could because people had so much going on and lots of competing demands and priorities during the pandemic. Next slide. So this is the participants around the country that participate in this work. We had over 100 organizations doing evidence-based programs. And I'm excited, you'll see the stars here. I'm excited talking to CDC before this presentation that we have new states represented doing EBP work through the CDC Arthritis Grant. So I know I've seen West Virginia and Oklahoma on the line. And we have a couple other new states, I think Montana I saw. And so we're excited to kind of put the stars on the map so we can get more folks involved in this evaluation work. Next slide, please. So I want to first talk about what we did and learned for the outcome evaluation, then I'll talk about the process evaluation, and then we'll open it up for discussion. So really the goal of this evaluation was, do participants in these remote programs improve their health over time? We know their health is improved in in-person programs. That's what established the evidence for evidence-based programs. But do those outcomes still maintain when people are doing it by phone, by Zoom, online, et cetera? Next slide, please. So we did a longitudinal study, multi-site design, using mixed methods in a single group. So there was no comparison group, there was no randomization. We basically just said, come one, come all. As I mentioned, those recruitment methods, we really tried to get different types of organizations and participants. And then we basically said, how are you doing when you enroll in the program? And then follow everyone 6 months later. So we had 37 organizations for this outcome evaluation from 16 states. And we didn't just collect participant data, we also made sure we collected data from providers. And we did both surveys and interviews to get both that kind of what's happening quantitative data, as well as how and why it's happening qualitative data. For our analysis for the quantitative data, we use descriptive statistics. We use pair t-tests to kind of measure this change over time, and effect sizes to look at magnitude of change. And then we use thematic analysis to pull out kind of key themes from the qualitative data. And then what's called joint display tables to compare that data, the quantitative and qualitative, to have a richer picture of what's happening. Next slide, please. So these were the 5 programs we included for the outcome evaluation. We tried to select programs that use different remote methods and cover different health topics. I will say 3 of these programs are the SMRC self-management programs, chronic disease, chronic pain, and diabetes. And then we also had enhanced fitness and walk with ease, with our both physical activity programs. Next slide, please. We used basically the same measures across the different programs, because we wanted to kind of get a sense of what are these key outcomes of interest for older adults and their families, for people like you who are providing the program, as well as policymakers that are funding this work. So here you can see the different measures here, and I'm happy to share if these measures are of interest for your work and your evaluation. Let's not reinvent the wheel. Happy to share these offline. My contact information will be shared at the end of this presentation. Next slide, please. So in terms of what we learned through the process of data collection, it was really important, given what a hard time it was at COVID, that we pick outcomes that matter to stakeholders, but also the COVID context. So we didn't just measure physical health outcomes, but we also measured mental health and social health and tech access outcomes because of COVID. We tried to minimize respondent burden, but you never can fully do that with an evaluation. So we tried to give a lot of time to review outcomes. We tried to build in data collection to the first session. We used lots of different modes of data collection plus incentives. And then we tried to centralize the follow-up data collection at our center. Next slide, please. These are the characteristics of participants in the outcome evaluation. We have 586 program participants fill out surveys when they enrolled in classes. You can see they were an average age of 64. It was predominantly women. We had 36% of folks identify as a person of color, and majority of those participants were Black or African American. And we also had participants from 6% Latin X, 4% Asian, and 1% American Indian Alaskan Native. People were living with, on average, 2 chronic conditions. And you can see here that half of those were living with hypertension, 45% diabetes, 28% mental health conditions, and 25% osteoarthritis. About a third found it hard to pay for the basics, and a little more than a third were living alone. And a little less than half found that their health was poor or fair when they entered the program. Next slide, please. So in terms of representation, when we look at the national data versus our evaluation, we really had women, Black and African American older adults, and rural populations overrepresented or represented with the same as the national numbers. We were disappointed that we had underrepresentation from Indigenous communities, Asian communities, and Latina communities, and so that's work we need to do. We tried to partner with organizations serving those communities, but we found that for some of those organizations, they were particularly strapped during the pandemic, given the disproportionate impact the pandemic was having on communities of color. So this is work we need to do better. And if you are on this line and serving communities that were underrepresented, we would love to talk about future partnership. In terms of retention, we only had half of the people who filled out baseline surveys fill out follow-up surveys. We did phone calls, we did emails, we worked through the organizations. Ultimately, people were hard to connect with because they had either moved or no longer had phone access. or were just no longer engaged with the organization. Next slide, please. So these are our quantitative findings. So basically, we looked at whether change over time from when they started the program to 6 months following the program, whether the improvements over time were statistically significant. So what that means is that those changes we don't think were due to chance. We think they probably have something to do with participation in the program. And you can see that the outcomes are slightly different across programs, but there's some similarities. So many of the programs include improve physical activity and self-rated health. On the left-hand column is kind of the overall findings. So that's when we combine participants of all programs. We see that health and physical activity, as well as sleep, depression, and loneliness were improved. And then you can see individually by programs that some of the outcomes were different, which might be expected. So for example, we would expect potentially hypoglycemia to be improved with the diabetes self-management program, whereas physical activity being improved with something like enhanced fitness or walk with ease, and pain being improved with chronic pain. Next slide, please. We also looked at kind of the amount or magnitude of change. It's not just whether it's significantly changed, but like, is the change meaningful? And we were pleased to see that there were some outcomes that people participating in these programs improved over time. And they kind of align again with what we expect based on the program focus. We also found that in general, even if they didn't improve over time, 20 to 54% of participants, depending on outcome, depending on program, maintained their health. And so that's a really important thing with older adults because we're trying to prevent further decline. And so even maintenance is a positive outcome when we're looking at folks who are aging and potentially at risk for their health declining. Next slide, please. So qualitatively, there were a couple of themes that came out of our interviews and conversations with participants and providers. We found that participants talked about really participating in these programs helped change their health promotion knowledge, attitudes, and practice. As one diabetes self-management participant shared, I feel as if this program literally changed the trajectory of my life. Prior to it, I was diagnosed as pre-diabetic and I was put on medication, which made me very sick. My next option was a very expensive diabetes drug. But through following the program, I learned about insulin resistance and what I could do to combat my descent into diabetes. I was encouraged and coached in inspiring ways, and I'm now barely considered even pre-diabetic. Next slide, please. People talked a lot about the social benefits of these programs. And again, remember that COVID context, right, where we were disconnected. They felt less alone, they felt more camaraderie, they felt more comfort and more connection. As one Walk with Ease participant, I'll read this bottom quote here, said, I did appreciate the opportunity to meet with a group assigned to me and to get the encouragement to get out and walking. So it's that connection, both socially that feels good, but also that connection to help people promote their health as well. Next slide, please. We also learned from the participant interviews that, you know, for many, offering the program remotely, whether by phone or by toolkits or by video, really improved access. For many, they didn't feel comfortable leaving their house. It wasn't safe. For others, they talked about the convenience of it. Maybe they were somebody who was providing caregiving for an older loved one living with dementia and just having to find respite care and figure out how to get 2 hours to go to and from a class was challenging. At the same time, while access was improved, there was discussion about challenges to access to technology and comfort. And I see in the chat, there's some comment about this, you know, that having people who don't have access to devices, who maybe don't feel they have privacy in accessing the devices, or maybe just don't feel comfortable. There's also issues around HIPAA and IT. And so these kind of things came up, and this presents real opportunities for both national and local support in terms of how we help people get access to technology and safe technology and can use it well. The other thing that came out is people really felt they wanted to do their programs again. And so these programs are meant to be time limited and build skills, and you kind of take them and run with them. But we heard from many this desire to kind of keep going. And some of the evidence-based programs actually have sort of booster or post-program supports. And other organizations have created kind of support groups to do skill building going forward. Next slide, please. So this slide, I apologize, it's kind of small on my screen, so this might be small on your screen. This was a slide that kind of talked about what providers shared with us about what they saw as the benefits of doing programs remotely. So for participants, it was again that improved health and reduced isolation and loneliness, improved access and comfort using tech. But they also talked about how the programs really helped improve access to other supports and services. So many of your organizations do tons of things, right? You deliver food to people's homes, you get people access to better medical care and affordable housing. And so the evidence-based program could become sort of a gateway to get in connected to your organization and they get access to other services. Next slide, please. The other things that providers talked about were benefits for them, right? We were all struggling during COVID too. And how do I do my job? And how do I connect with people? And so providers talked about also their improved health outcomes and reduce isolation and loneliness, and then also their improved access to technology as well. And these findings we saw from both interviews as well as some surveys where we asked questions about benefits for providers. Next slide, please. So kind of several implications of these findings. I mean, in general, we feel pretty positively that while not all outcomes were improved and while access wasn't improved for all, these themes kind of came out overwhelmingly from both the survey and the interview data. So we don't think we're doing more harm. And if anything, we think remote programs could provide one tool in your toolbox for promoting people's health and giving them access to the programs. I think the strengths of the project was we tried to really be older adult equity focused, engaging people living with multiple chronic conditions, communities of color, people experiencing poverty. I think we could do a better job though with some of the underrepresented groups, as I shared earlier. We had outcomes the same across programs. We used different methods to understand the what, how, and why. And we tried to make it very practical and doable. We do, though, there's quite a few limitations that I want to be honest about, right? This is a single group convenient sample study. So we don't really know whether the outcomes improved in health because of the walk with ease or because of chronic disease self-management or because of something else that was going on in participants' lives. So you would have to have a randomized trial to do that, to remove that bias, as well as a comparison group to see whether people would have improved if they did not do the program. We also only look at group-based programs for the outcome evaluation, so there may be different benefits or different challenges when we're looking at one-on-one programs. So lots of opportunities for future research and practice. Next slide, please. So I'm going to talk a little bit about the process evaluation. This work has been presented before, so some of you might have seen this before, but I want to just make sure, since there's some folks new to this work, that I do a quick overview of that, and then we'll open it up for discussion. So this project really tried to look at reach, who is and isn't being reached by the remote programs, and who's adopting these programs, and kind of what can we learn about facilitators and barriers to delivery. Next slide, please. So this was also a single group, multi-site mixed method evaluation. This one, we include 31 different evidence-based programs, almost 200 providers from over 100 organizations in those 33 states that you saw on that map. We also did a mix of participant and provider surveys and interviews. Next slide, please. So we selected these programs based on ACL and CDC recognized programs for remote delivery. The Administration on Community Living had been gathering information throughout the pandemic to basically establish which programs were being done remotely with quality. And so the ones that were included in the process evaluation are listed here, many of which people called out in the chat. I saw DPP, Enhanced Fitness, the Arthritis Foundation Exercise Program, Pearls, the SMRC programs, Walk with Ease, and Tai Chi. We also had some other programs, as I mentioned, there were 31 total, but the sample sizes were so low that we didn't include them in some of the evaluation, but we included them in some of the overall data because we didn't want to have anybody be identifiable from the evaluation. But a mix of health topics, a mix of remote formats for this evaluation. Next slides, please. So these are the characteristics of the leaders. One of the cool things about this evaluation is we often talk a lot about participants, but we don't talk enough about the workforce, right? The people that make this happen, and that this becomes an opportunity for promoting their own health and well-being as well. So majority of the leaders that participate in this work were women, a third were caregivers, 28% identified as a person of color. Interestingly, 27% identified as rural, even though only 14% of participants identified as rural. So that means that we have a lot more folks doing this work in rural areas, and it could provide an opportunity for working in different parts of the state and maintaining your workforce. We also found that about a third were living with multiple chronic conditions, about 28% had financial hardship, and about 17% were living alone. The other thing to call out is 43% identified as a community health worker or other lay health provider, and about a quarter were a certified health professional. Next slide, please. So in terms of learning about collecting data during the evaluation, we mainly did Zoom interviews as well as provider surveys. And we tried to get a lot of different types of folks in the EBP workforce. So participants, leaders, delivery organizations, and administrators, because you all bring a different lens to how this work is working and how it's not. Um, and we also tried to make sure we included organizations and people who both were able to do remote programs during COVID, as well as who weren't, because we wanted to make sure we didn't kind of bias the findings towards like the rock stars, the people who had it all work out, because we know that there were a lot of challenges and we wanted to try to candidly evaluate this work. Next slide, please. So in terms of reach, first we looked at what new populations are being reached. So people who've not done evidence-based programs before. We saw people who are caregivers, who are homebound, who face transportation barriers, who live in rural areas, who have limited English proficiency, and who prefer remote. And some of this was the reality of remote. So for example, if you're serving a language group where you don't have somebody who speaks that language in that community, but they speak that language in a different part of the state, you were now able to reach them because with remote, you don't have to be living in the same place. Next slide, please. In terms of who are not being reached, this is kind of similar to what we see in the outcome evaluation. People who don't have the devices to do the work, who don't have reliable internet, who might have limited literacy with using tech, or don't have real trust of using tech because of some of those maybe privacy issues. Those are the folks who we really need to do a better job at trying to engage and address some of those access and comfort issues to do remote work. Next slide, please. In terms of looking at facilitators of implementation, people really talked about the different adaptations that were made, largely to how the program's delivered in training. There were very few content changes. The content changes mainly had to do with safety. So for some of the physical activity programs, they changed a few of the exercises to make sure people were safe doing them in their homes. Providing tech support for not just the people who participate, but the people who deliver, doing different ways of remote so that we can really make sure folks have access. So if you can do something by phone, do that so that people who don't have great internet or a device can participate. And then this just sense that like, we're figuring this out. This is getting easier over time. One of the program staff shared, well, we've lost a couple of instructors, so having that remote training option for instructors and not necessarily needing to have a master trainer available to come and do the training or sending people away to training, that's really helped. So remote didn't just happen with program delivery, but it also happened with building workforce capacity. So distance training really expanded during COVID, and everyone has talked about how that's really helped with making training more accessible to support their workforce, which may change over time. Next slide, please. In terms of barriers, for some, as I mentioned, some of the group-based activities just weren't feasible. There is some concern about for some people and communities, we are going to widen the digital divide if we only offer remote. So we need to be thoughtful about offering in person where appropriate, as well as providing support for tech. It can be more resource intensive in terms of the tech support and devices. So you got to kind of weigh that as an organization. It can be hard to connect casually when you're not in the in-person room, but in the Zoom room. And then there can be some engagement challenges that you have to be more creative and work harder both during and before the program. As one staff and leader said, the cost has gone up. If there was just one instructor, it would obviously be less, but if there's another, it adds to the cost. So having that tech support is a real cost. Next slide, please. These are some of the implications. This is from the paper that our team published on the process evaluation. But an important thing to think about as we think about kind of the now what when we open it up for discussion. It's not just about implications for you all and your participants, but also the kind of system around us in terms of how does remote delivery help give people more access to programs as well as the workforce doing this work? And how do we basically think policy-wise in doing things like broadband for all and making that digital divide less. Next slide. So in summary, you know, this really tough time of COVID actually did create an opportunity to address some barriers we've known about for years with doing evidence-based programs. How do we improve access and equity with offering these things remotely? It also, I think, is a nice example of how do we do an evaluation that like will help you all, and how do we do it during a tough time and bring together different stakeholders from different places to do it. And at the end of the day, we see this as potentially an opportunity to improve health and access. And so looking forward to talk about that during the chat. So I think my next slide is just my contact info. I have some discussion questions, but I feel like you all might have questions too. So those I'll just keep in my back pocket. And I'll put my email in the chat because it's kind of hard to see with the blue. So I apologize for that. But here's how you can get in touch after today. So Jade, I'll turn it back to you in case there's anything you want to say. Otherwise, we'll open it up for questions.
Hi, everyone. We definitely want to thank you all for participating. We appreciate all of you commenting and letting us know where you all are participating from, and letting us know, what type of programs you've worked on. This slide just has our Sophie links that you can access everything from. Our webinar will be posted on our eLearn page, which you can access. As long as you have a membership, you can access it. Memberships, you can access the information even if you don't have a membership. This webinar will be free, so we will be good. And as well, it will be posted on our YouTube page so that you all will have access to that. So thank you all for that. And if you have any additional questions or anything like that, you can reach out to our Sophie team if we have any resources or anything like that, that we can get to you. So I'll go ahead and put my email in the chat as well. And then I'll go ahead and turn it back over to you, Leslie, because we did have a question from Kelly in regards to some of the stuff that you mentioned earlier, issues with tech issues and stuff like that.
Sorry, Jade, you cut out just right at the end there. Was there a question or you want me to just facilitate the discussion?
You can facilitate the question. There was a question already posted in the chat from Kelly, which you briefly touched on. She was asking about,
Yes.
difficulties with tech support and stuff.
Yeah, totally. Thanks, Kelly. And just for folks who aren't in a place where they can read or see the chat, Kelly, they're just starting the Arthritis Foundation exercise program in a community room. One of the settings she gave an example of was a low-income county apartment building, and they've had issues getting access to Wi-Fi for programs because the community is a little nervous about them accessing Wi-Fi. And concern that people might be able to access HIPAA protected information, such as like the incomes of the residents that are living there. So it's really challenged their ability to deliver. And then as a result, residents are kind of in their private apartment doing the work. And so they're not together in a group. And so just kind of calling out the reality of both the privacy issues and the Wi-Fi and the access issues. And so asking about whether are there ways we can get kind of larger management companies of lower income apartments who could kind of be on board with this. I think it's a really great idea, Kelly. I mean, I think I've got two thoughts and two things I think we heard from the evaluation. One is sort of getting leadership on board to help solve this problem with you. This doesn't have to be your job as a foundation or a social service organization. And if the housing management company is on board, they might be able to come up with ways that folks can have access in a way that they feel safe in terms of participant information. This is where it's also like the value proposition for the housing site as well. Even before COVID, many organizations doing evidence-based programs were sort of marketing or selling their programs to low-income housing as a way to keep residents happy and healthy. As part of the resources that they offer in the community. I guess the other thing I've seen is just when you kind of hit a wall and you can't get access within the building, people have gotten creative with just other places to do this work. So for example, many libraries offered hotspots, like lending hotspots and tech during the pandemic and continue to do so. So if that would be a way for them to access the either not necessarily having to go to the library, but basically being able to check those out to offer those to residents. And then it becomes a way that potentially they're accessing it, but not using the network that the management company is about. I would welcome, though, if people have other ideas on how to address this from your own work. I think that'd be super helpful.
If anyone has any answers, please feel free to raise your hand at this moment. You can speak and ask your questions or just add any feedback that you have. But we did have another question, Leslie, in the chat from Miss Christina, and she's just saying she's curious about how appealing online EBPs would be in a non-COVID time when
Yep.
there are more opportunities for engagement. Do any of your findings give you a sense of this?
Yeah, great question, Christina. So on the one hand, I think yes, there's still an appetite for doing evidence-based programs remotely. And it's largely because of the slide I talked about just a little bit ago, talking about how people who don't traditionally participate in evidence-based programs now can. So that person who is living with a lot of pain and getting out of bed is just like, they're not going to do it some days. And that happens to be the day that their chronic pain self-management class is offered. Or they're caregiving for a younger or older loved one and just trying to figure out where to have respite or to even get respite is challenging. So I think there's an appetite for remote for people who particularly did not have great access to the programs when they were done in person. I do think though, the other thing we heard was like how nice it was to connect with people and also some of the challenges of doing remote. And so I think for some organizations, they see remote as like part of their toolbox, but not their only toolbox going forward. So for the people who can do in person and want to do in person and they're able to offer in person, they're doing that. And then remote becomes an option for people for whom actually it's better access. The other thing we saw from some of the one-on-one programs was they would actually do a hybrid within the program. So they might start with remote as a way to get connected to somebody who's more isolated, maybe in a rural setting where it's just hard transportation wise. And then they would kind of do in person as one of the later sessions as a way to bring someone into the center or bring someone into the library. So kind of shares resources, lowers resources, but then also has a chance for in-person engagement. I'm curious if you have thoughts from your community of what people are saying, but I think we're hearing kind of a both and going forward.
Yeah, I've been hearing that that for certain programs, virtual just doesn't work very well. Like the Tai Chi, I guess, is very hard to learn virtually.
Mhm.
Um, but then something, something that's like Walk with Ease, where you can kind of like meet virtually and talk and then, walk on your own or something like that, that could work very well. Yeah, in Vermont, AARP did lots of virtual programs during COVID that they were very, very successful with. And we were thinking about doing a model sort of with them. They did like a bicycling and a couple different kinds of classes. And we were thinking about replicating this. And then hearing this, I was thinking, oh, is this something that only really worked because it was COVID? And
Uh-huh.
people wouldn't really engage otherwise. But I take your point that for some people, it just does work better, especially in rural places, which
Yeah.
Vermont has a lot of.
Yeah. I mean, it's like looking at your barriers to participation and which of those does remote solve and which of them does remote not solve. I think people have gotten a lot more used to engaging virtually than they ever have. I mean, COVID, like it was such a pain, but now we're all much better at it. But your point about Tai Chi is well taken. Some of the programs people maybe feel more comfortable in person during Tai Chi, and then perhaps maybe during later sessions, they're more comfortable doing it in their home. And then you minimize that. How do I get to the center and get someone to pick me up, etc. So I think that's why people see this hybrid kind of approach going forward. Yeah, great question.
Thank you.
Thank you. What else is coming up for folks? You can raise your hand, or if you type in the chat, I'm happy to read it out so everyone can hear it.
Well, thank you, Christina, for bringing up your question. I definitely think that it's relevant in the time. And like Leslie said, a lot of things have changed and people have gotten more adaptable, but not everything will be able to be adapted into remote just because of how difficult they are. So always looking for new ways to be able to convert programs to be able to be more accessible for everyone. Do we have any additional questions? Please feel free to shout them out, raise your hand, put it in the chat. We definitely appreciate everybody participating, especially those of you who are new to the community and the program. We definitely hope that this information has been beneficial to you all. Leslie's been working on this information for a while, so we're glad that she's finally had the opportunity to be able to present her findings and share that all with the community. So it's a really great opportunity for not only herself, but Sophie in a partnership with CDC to be able to address these issues and put a little bit more focus on it. Again, this webinar will be posted to our eLearn site, which you can access. We'll create an account. It'll also be posted on our YouTube page for you to be able to access. The slides will be on our eLearn site as well, so that I know there was a mention that some of the charts were a little small, so you'll be able to review those as well. And if you have any additional questions or anything, please let us know. There is a fact sheet that is available as well through our arthritis section on the eLearn site that Leslie has completed with her work as well. So you guys can see that there. But if you have anything else, please feel free to reach out to either me or Leslie. Both of our contact information has been shared there as well. And if you aren't able to access that for any reason, reach out to us to our info@sophie.org email box, and I'll be happy to help you with anything that you need. So thanks very much for everybody to participate. And again, one more thing. There's one question from Kelly. She just popped in the chat. Are there any new grant opportunities for our work? Leslie or maybe Anamika, would you be able to answer this question?
Well, for the evaluation work, that work is completed, but I work out of a CDC-funded prevention research center, and we're always looking for opportunities to do more research and evaluation in partnership. So, Kelly, if you send me a note, I will keep you in mind. But CDC can probably comment on whether there's any particular opportunities from CDC around remote evidence-based program work.
Yeah, hi, thanks, Leslie. This is Anamika with CDC. We don't have any new grants per se that are coming down the pipeline that I have purview on right now. But of course, if there is, we would share them out and they would also be posted to grants.gov.
All right. Thanks, Anamika and Leslie, for sharing that. Again, you all have our contact information in case you need to reach out for anything else, but we definitely want to thank you all for joining us and Leslie for taking the time to share this information after all the hard work that you've done to complete it. So just thank you, everyone. We really appreciate it. All of the resources and information we posted to our eLearn site. Leslie, is there anything else you would like to share before we close out today?
I just want to thank everyone who took the time to join today. You're doing amazing work to support older adults, and I hope this information can be of use, and looking forward to partner going forward. And many thanks to Sophie and CDC for their leadership, both in funding as well as pulling together today's conversation and other resources. So thank you. Look forward to continuing to talk.
Yes, definitely. This is always a great opportunity to be able to share the information further, get new people interested, and be able to work on the already existing information. So thank you all. I'm going to close this out. I hope you have enjoy the rest of your day. And again, this information will be posted, and feel free to reach out to us if you have any additional questions or need any further information. Thanks so much. Bye.